Yeah. So I was struggling to figure out what image to start the presentation with. But hey, my head with the virus on the forehead. Why not? That seems appropriate. And because I'm an epidemiologist, I've also brought a CO2 detector here to show you the air quality in this room. It's extraordinarily good. So you should be happy that we have taken precautions that are COVID safe here. So I'm going to talk about communication. And it's one of those challenges that we all are struggling with in the course of this pandemic. I want to begin with a paper that I always talk about. It's from 2007, which was written as a post-mortem of the SARS epidemic that Colleen was talking about. And this is a favorite paper of mine because it ends with 3 recommendations for the next pandemic. One is to remember that the old technologies are the best technologies, mask wearing, etc. 2 is that animal husbandry is bad for human health. That's part of my vegan propaganda, so I'm just putting that out there. And the third is that transparency in communication is everything. And we have forgotten all 3 of these lessons, in particular the last one. And the thing about transparency in communication is there isn't actually a lot of formal frameworks for how to conduct public health communication well. And the handful that do exist all land upon the same set of values. They include accuracy, honesty, and promptness. The thing about those values and about all the guidance around communication is that it assumes a fundamental trust in the person giving the messaging, the person in front of the podium. And as we all know, trust is at all-time low right now. In fact, this statistic should horrify you. It shows that during the course of the pandemic, the proportion of Americans who felt it was okay to harass and even threaten public health officials went up. It's okay to harass and threaten public health officials. That's horrifying. So what affects trust? Well, uncertainty affects trust, I would argue. And we've seen during this pandemic a whole lot of uncertainty around mask wearing, the guidance around that shifted dramatically, uncertainty around what the vaccines are for, what they can do, the messaging around that shifted dramatically, uncertainty around whether or not COVID is airborne, that's still ongoing, right? So that is confusing for most of the public. And the thing is, uncertainty is science. It's a bedrock of science. Science is not a set of facts. Science is a process of discovery. And that is largely unacknowledged by the public and ununderstood by the public. And as a result, it is fomented and used as a divisive prizing mechanism by those wishing to sow discontent in our society. So here's a lovely quote from Timothy Caulfield. Disinformation strategists are weaponizing scientific uncertainty and trying to create distrust. They're trying to create information chaos. So we have uncertainty and we have the deliberate fomenting of distrust. Why are they doing this? Well, they're driven by, one could argue, ideology politics. My side believes this, your side believes that. Social identity politics. My values are this, therefore these observations conform to my values. Profiteering grifters, we know who they are. They've been well identified on Twitter, but more popping up all the time. And foreign interference, which I'll talk a bit more about in a bit. More horrifying statistics. Again, this is American data. This shows us that trust in government officials in general is declining. The last 2 bars in each of those categories shows a declining trust in medical science, health science, and military even. And here we have a declining trust in science overall by a variety of categories. The one I draw your attention to is the bottom one. This is Republicans in the US are more likely to have lost trust in science since 1970 to the present day. And that underlines the ideological divide in how science is being absorbed by the public. It is about values, it is about other things, but it's largely about political ideology. And this, we can't forget this also. We had the fomenting of distrust in a COVID vaccine well before there was a COVID vaccine. And this tells us that a lot of this is driven by, again, social value and community groups and so forth. So let me pivot for a second. We're here to talk about borders, right? So I would argue that there are 3 things that the countries who did COVID well early on did well. Those 3 things are: 1, they got really good at case detection, at testing. Number 2, they acted early, they acted hard. And number 3, they got good at monitoring and strategizing the closures of borders to prevent the importation of new infection. Good examples of this: New Zealand, Bhutan, maybe Singapore, maybe Vietnam, etc. It's these last 2 points that I want to draw your attention to, because they're related. And yet, this was not well communicated during the pandemic and created a lot of discontentment. So, was there ever any real attempt to explain why border restrictions were necessary in this country? I would argue not really. So the things we could have communicated well was the risk of seeding events caused by importation of infection, the risk of importing new infection, the explosive nature of exponential growth, which I'll talk more about in a bit, and how at the time we had very limited testing capacity for isolating people, and capacity for contact tracing. So additional importation would have been quite a stress on our system. But despite the fact that these were not well communicated, the opposite was well communicated. So endless newspaper articles, tweets, Facebook posts on why border restrictions were not necessary. Here's just 3 examples from The Economist, Financial Post, CTV News, showing how it was cruel, not data-driven, and so forth. So the information balance was not there. So my thesis in this presentation and in my paper is that communication in this pandemic has been hobbled largely by 2 forces: innumeracy and disinformation. And again, as an epidemiologist, I think about disinformation as the pathogenicity of communication, and innumeracy as the susceptibility of the population to that pathogenicity. The disinformation wouldn't have nearly as much purchase if our population wasn't as well prepared to accept it. So I'm going to begin the innumeracy portion with this quote from a physicist who says, "The greatest shortcoming of the human race is our inability to understand exponential growth." And this is an ongoing problem with science literacy. So a German study found that people mistakenly perceive linear growth when in fact it's exponential growth. Our brains are hardwired to think in terms of linear growth, throwing balls, intercepting cars, passing in your vehicle, and so forth. But exponential growth is not something we encounter naturally in our evolution, so we're not prepared to accept it. And this inability influences political decision-making, they argue, in matters of life and death. That's a scary, scary thing. So as an example, in April 2021, Esyllt Jones, who was the Ontario Solicitor General at the time, was asked why the government had not yet, or was slow in enacting pandemic restrictions that many experts were calling for. And her answer was, we wanted to make sure the modeling was being seen in the hospitals. That was a horrifying answer to many of us. It really underlined the fact that she and the government or other decision makers did not understand the nature of exponential growth. By the time you see it in the hospitals, it's too late to act, really. So Richard Baldwin describes exponential growth as occurring in 2 phases. First is the slow, imperceptible progress phase at the bottom of that curve there. And the second is the explosive growth phase, when it's chaotic and scary. So at the bottom part, the slow, imperceptible phase, you're not really scared. Nothing's going on. But that's the time to act, because by the time you're in the explosive phase, it's too late to do anything moderately. You must overreact. And again, with pandemic closures, with border closures, the evidence shows that when it was effective, it's when it was enacted early and hard. So still on innumeracy, I want to point to the conflict between individual risk and population risk. And this is an ongoing cognitive challenge here. A rallying cry of COVID minimizers has been, why be afraid of a disease with a 99% survival rate? Frankly, if you look at this from a population standpoint, you should be absolutely terrified of a disease with a 99% survival rate. So this comes from the infection fatality rate, assumed to be about 1% prior to vaccines. That's the proportion of infected people who will eventually die of the disease. So imagine, well, there are about 12.6 million Canadians who commute to work every day. If 1% of those were to die, that's 126,000 dead. That's a tragedy by any estimation. So that's the distinction between individual risk and population risk. Maybe at an individual level, 1% doesn't sound like a lot. At the population level, it's staggering. And yet, a lot of the messaging to try to combat that 99% survival rate messaging has again focused on the individual risk. The first part of this ad, for example, saying, yeah, it's 99% survivable, but you can survive with, with disability and suffering, et cetera, which is true, but it misses the grander point that your society would be hobbled by a 99% survival rate if enough people get sick. I don't have time today to discuss other elements of the distinction between individual risk and population risk, but I do want to draw your attention to something Colleen mentioned earlier, which is the threshold for action. We have an ongoing debate between those advocates of evidence-based medicine and those advocates of public health medicine, if I can call it that. So the threshold for action in evidence-based medicine is much higher than the threshold for public health. We can wait for the clinical trials, the perfect systematic reviews. We often cannot wait for that for public health. Enacting a mask mandate, we can't wait for clinical trials. Probably can't do clinical trials, frankly, it's probably unethical. But what we can do is look at laboratory studies, modeling studies, and so forth. But the inability to conduct proper clinical trials has been landed upon by minimizers to exacerbate the division between those who resist COVID restrictions and those who don't. So the disinformation portion of my thesis, fighting the infodemic. So CSIS has identified that threat actors are fomenting discontent in our society by pushing COVID disinformation. As a result, public health communicators are now soldiers in a war against bad information, not just providers of good information. That's new. So here's a study by the RAND Corporation. They found that Russian media were advancing conspiracy theories in the USA about coronavirus. The US Department of State has a lengthy report looking at the motivations and mechanisms that this is done by. One is they fund a handful of disingenuous writers to write nonsense. The second is social media is being used, as we know, to push bad messaging. We have proxy websites posing as real news sites that are being shared all the time by trusting, I don't want to say gullible, but trusting people. And we have bots that are amplifying disinformation and attacking people online for providing good information. And there are people in this room who have experienced that firsthand, I'm sure. So what are the goals of the COVID disinformation merchants? Well, one study suggests they are multiple. One is to boost the position of one political faction, to denigrate another. Another is to set the conditions for some argument in the future. And I don't know what that argument will be, but I'm afraid to find out. Sowing division is obvious. And lastly, in general, to reshape the geopolitical playing field in a very low-cost way. What does this mean for public health communicators like me and others in this room? It means that we can't just follow those handful of communication frameworks that I alluded to at the beginning. We have to combat actively falsehoods because they're better resourced, they're better organized, and they're more active than we are. And also, we have to invest in public science literacy to make sure that the public is better inoculated, pun intended, against bad ideas. So do you know the average number of people who read a peer-reviewed paper is? It's not well known, but it's assumed to be about 2, not including the authors, right? I think those are most of my papers. And the average number of people that view a YouTube video is about 3,000. Now think about the YouTube videos that push COVID disinformation. They're viewed by tens of millions, if not hundreds of millions. So science, proper science, moves too slowly to combat disinformation at this scale. We need more models, more ideas. I'm going to conclude just by saying that the old frameworks for public health communication have failed us during this pandemic. It is not sufficient to simply be honest and prompt. We have to be trustworthy, and we have to combat disinformation as we see it, sometimes getting ahead of the ball. Now, many are trying. This is not a complete failure. It's just that we're under-resourced, tired, and under attack all the time. And this is a society-level endeavor that begins with, again, investing in a decades-long plan to improve science literacy overall, so that this cannot happen at this level ever again. Thank you.
Thank you very much. I got my mic on here. Are you through the mic? No. Okay. Thank you very much. That was excellent. And I have questions. So everybody else get your questions together for the end of the panel. But we're going to move on to our next speaker who is joining us online as we continue this panel looking at the historic context of pandemics and their the effects of border restrictions and other restrictions on the movement of people. So our next speaker is Esyllt Jones, who is an historian and professor in the Faculty of Arts at the University of Manitoba. Really looking forward to this presentation, which is entitled "The Wolf and the Sheepfold: Borders, Containment, and Contested Discourses of Public Health in the Great Influenza Pandemic Era." Over to you.
Thanks very much for the introduction, and to the conference organizers for inviting me to present today on a subject that I care about a lot, the history of the flu pandemic of 1918 to 1920. Today I'm located in Winnipeg, which is on Treaty 1 territory, the original lands of the Anishinaabe, the Cree, Ojibwe, Dakota, and Dene people, and also the Métis homeland. It's also a region with its own very difficult colonial past, including histories of infectious disease that we're still learning a lot about. I'm going to speak without slides today, which I hope is okay. In her book, Imperial Hygiene, A Critical History of Colonialism, Nationalism, and Public Health, historian Alison Bashford has written, "Lines of hygiene were boundaries of rule. The whole mission of public health was that it formed an important part of the larger modern projects of nation or race and of colonization." This perspective has been very influential, but is also shaped largely without reference to the history of the global flu pandemic, which is seldom considered in the literature. In light of this absence, my paper today tries to explore some of the ways in which we might reconsider Canada's response to pandemic influenza, what it meant for boundaries of rule, political authority, and trust in public health. Well, public health discourse and practice at the turn of the century, the 20th century that is, was socially and politically contingent and interwoven with these histories of capitalism, colonialism, and in that period, a growing emphasis on racial difference. At the national level, prevailing public health discourses depicted health threats as external, not internal. Health at the borders was designed until the First World War, after which migration was increasingly restricted. To prevent diseased, or those viewed as diseased and physically or mentally disabled, from compromising the vitality of the nation. So borders were about policing who was allowed in and who was kept out. It was less focused on surveilling or controlling the movement of specific infectious diseases per se. Perry Anderson once argued that nationalism and internationalism are really two sides of the same coin. And so even as the nation and public health were intertwined, international cooperation in disease control emerged in the Western paradigm in the 1830s in response to cholera, with the first International Sanitary Conference held in Paris in July of 1851. Between 1851 and 1926, there were 13 of these conferences, and halting progress made toward international standardization of measures against epidemic disease at these meetings laid the groundwork for the Health Committee of the League of Nations established after the First World War, and ultimately for the WHO. It was acknowledged that countries could not effectively act alone to combat the global movement of epidemic disease, like cholera and plague, both of which were pandemic in the late 19th and early 20th century. International cooperation, though, remained elusive, and policing at the border through immigrant medical inspection remained the key emphasis of Western states, especially in North America. In the colonies, Asian and African colonies, for example, colonial rule deployed health and bodily politics in the struggle for territory and for legitimacy, and compulsion was frequent when implementing public health measures. Such measures frequently encountered resistance and criticism, and popular opposition to coercive strategies was a central factor in the gradual turn to a more voluntary approach to fighting infectious disease in the 20th century, along with the general ineffectiveness of coercive measures. By the time of the flu pandemic, compulsory measures such as isolation and quarantine and compulsory vaccination were viewed by many public health officials and experts as double-edged swords. And they were fully aware of how fraught containment policies might become. In 1918, the failure of Canada's national border and quarantine system to contain the flu virus was inseparable from the prosecution of the war effort. Military mobilization was key to the virus's movements across and within Canada's borders. Lines of accountability between the military and the federal government were unclear, and at the local level, health officers were frequently highly critical of military decision-making and its failure to adequately quarantine those exposed to influenza. With a permeable border and a lethal variant of influenza spreading across the country in fall of 1918, provincial public health legislation enabled local health boards to take an interventionist disease control approach that restricted human interaction, measures like placarding of homes where people had been infected, isolation measures for those who had the disease, and the closure of public spaces and schools. Critical decisions about which measures to deploy and when and how to enforce them were made at the municipal level. Unsurprisingly, these local responses were varied and consensus was lacking. In Winnipeg, which my own work focuses on, health officials initially opted against compulsory isolation and the placarding of those homes with infected cases. The health department employed education rather than compulsion. It tried to build on pre-existing relationships with immigrant neighborhoods, printing literature in multiple languages, working with immigrant organizations to support voluntary nursing and relief work specific to ethnic communities. Soon, however, conflict emerged between Winnipeg and the province of Manitoba over measures to limit public interaction. The provincial medical officer preferred a more restrictive approach and punishment for those failing to follow public health orders. Fraser, his name was Fraser, called for strict mandatory quarantine of everyone infected with influenza. And ultimately, Winnipeg's health officers had to change course. But strict quarantine was never effectively enforced. The health department was short-staffed. Health inspectors and police officers were themselves severely affected by the pandemic. Health department data suggests that about 4,000 homes were officially quarantined and placarded in 1918. Far fewer were inspected. There were 13,000 reported cases of influenza. The total number of cases would, of course, have dwarfed that figure and far exceeded the number of quarantines issued or enforced. Other provinces exhibited local and provincial tensions, although not necessarily in the same direction. In Ontario, the chief provincial health officer focused on educating local public health officers, physicians, and the public. He advised against the closures of schools, churches, and meeting places. But the Provincial Board of Health had no legal right to determine local municipal health measures, only to advise. And so some communities enacted public closures despite the province's recommendations against them. In BC, the closures of schools and meeting places was commonly referred to as town closures. Vancouver's health officer viewed public closures as ineffective and preferred sanitary and public health, public education. By contrast, 16 surrounding municipalities applied to the province of BC for town closures. And some of these municipal leaders clearly viewed Vancouver as a disease reservoir and requested that the province enforce a town closure on the city. Victoria asked that it be quarantined from the mainland if the outbreak in Vancouver couldn't be controlled. And as the pandemic intensified, public and political opinion shifted toward greater intervention. Ultimately, Vancouver was forced to compromise and close schools and places of public assembly. Saskatchewan illustrates another layer of public and local response. 45 towns in Saskatchewan informed the Canadian Pacific Railway that they wouldn't be allowed to drop off goods or people in their communities. At points all along the CPR and CN lines, mobs of angry and frightened townspeople congregated on station platforms to enforce a self-imposed isolation regime, historian Maureen Lux has written. At Lloydminster and North Battleford, armed guards patrolled roads in and out of the community. To assert its decision-making authority, the province argued that these local measures were illegal and not in keeping with public health advice. Historian Mark Humphreys has referred to them as vigilante. But the question was, who had the right to decide? Although local public health responses were diverse and arguably inconsistent, public calls for greater intervention weren't infrequent. Public health decision makers had to balance competing viewpoints and interests. And at the same time, some members of the public ignored education or advice, for example, to limit contacts and to avoid crowds. Not all mandatory measures were supported. In Alberta, for example, where the wearing of masks was compulsory, which was actually unusual in Canada, masking was publicly ridiculed and resisted. These examples illustrate that boundaries around individuals, families, communities, nations, and public health authority were contested concepts during the flu pandemic, and not necessarily in the same ways we might expect in light of our COVID-19 experience. Flu's aftermath contributed to changes in public health, and I want to talk a little bit about that, but also revealed how fragile was public trust and legitimacy. In 1919, the country's first National Department of Public Health was formed, and reformers had long called for greater national role and coordination, but the pandemic proved the catalyst to the department's creation. Some spoke of the new department as essential for national security, or as did Peter Bryce. Some of you will recognize the name Peter Bryce because of his role in exposing tuberculosis in residential schools. Bryce referred to this as a reflection of a trade-off between individual freedoms surrendered and sanctions in order to protect, quote, community and nation and for mankind. By contrast, for some, the pandemic illustrated deeper flaws in notions of health, nation, and border. Social gospeler Newton Roll argued, we may think in lines of nationality. We may try to build up walls between one nation or people and another, but humanity is essentially one, and that which affects any for weal or woe affects all. This perspective echoes voices in multiple nations, as the British Ministry of Health commented in 1921 regarding influenza. There is no question of shutting the wolf out of the sheepfold. At the first post-war meeting of the Permanent Committee of the International Office of Public Hygiene in June 1919, the president referred to the 5 years since the last session of the group as more like 5 centuries. Historian Norman Howard Jones argued decades ago that, quote, the idea of erecting barriers against contagion was invalid, and the quarantine concept was an obsolete scientific superstition. And yet in Canada, as elsewhere, this was less a departure from pre-pandemic public health thinking than it was a continuation of longer-term developments. Little was, or has since been said, of community demands for stricter and more effective measures, of micro-authorities, as Alison Bashford has recently written in her piece on flu and borders, or public interventions at the local level. How these complex responses to flu shape public health on the ground and how they impacted victims and survivors, thus is a more nuanced story than the ones we sometimes tell in history. Containment and control were not primarily issues of nation during the flu pandemic, and pandemic tensions were often spatial and critically involved the question, who decides? And we still have more to learn about how public health legitimacy and authority was constituted during and after this pandemic crisis. Thank you.
Thank you very much, Professor Jones. That was fantastic. And again, lots of questions in my mind and looking forward to asking those, but you've both done a great job staying on time. I'm going to introduce our next speaker, whom I'm very excited about hearing from. This is Professor Chidi Oguamanam. I'm personally very interested in what he has to say, in part because I believe Chidi has a connection to West Africa, where I lived for a decade of my life, but also because if I can indulge myself in a little personal story about borders and pandemics, my son got married to a woman in northern Uganda last year, and we were supposed to go to the traditional wedding at last Christmas time, and darn if Omicron and border closures across Africa didn't cancel our ability to go to Uganda. So we rebooked for this Christmas because now there's a baby coming. And darn if there isn't Ebola. And I'm thinking, are we ever going to get to Uganda? So that's obviously very small scale to the much, much larger issues. But border closures can certainly get in the way of personal plans. But Chidi is going to talk at much more serious depth on this matter. Chidi is a professor in the Faculty of Law at the University of Ottawa, so probably many of you know him. He holds the research chair in bioinnovation, Indigenous knowledge systems, and global knowledge governance. I'm really looking forward to this talk called Bordering the Diseased Other, the Unhealthy Burden of Global Public Health. Over to you, Professor.
Thank you very much. That is a very kind introduction. I want to use the opportunity also to thank the organizers, my colleagues, our precious students behind the scenes, and my co-panelists for this opportunity. As introduced by our chair, I have moved from bordering the disease order to the fallacy of disease directionality. I had the opportunity of reading my colleagues' papers and abstract, and I figured that I would be able to position myself, taking advantage of what I call my privileged positionality as an African voice in this very complex conversation. And therefore, bear with me for the tweak in my original title. The message remains the same. We're talking about the unhealthy burden of the global public health. And I want to emphasize the global in my presentation. And therefore, the map would look like the very evolution of global public health, which has its roots in colonial migration. The Europeans going to other parts of the world and trying to practice their business and trade of colonization and the political influence. And of course, I took the liberty, and that is my absolute discretion, to split the history of global public health into two core phases: the Eurocentric phase, and that was the time of racialization of disease and isolation of the diseased order, and the fallacy of disease directionality. And of course, I heard Colleen talk about the plague as the Black disease, and those are the kind of things you see that was actually engineered by the colonial mind. And then we go to the modern era, where we try to bring some degree of inclusion and constitutionality, and try to allow science to determine the decisions we make in this space. And for what Lisa has said, coincidentally, I decided to pull off two practical examples of the experience of Africa in relation to recent global public health crisis, specifically in relation to Ebola that has actually broken out again in Uganda, as you have heard already. And of course, the COVID-19, specifically what I call the South African curse, the Omicron variant. And I'll share some concluding remarks with you. Now, the global phase, the Eurocentric and the colonial phase, This is really very important. The reason I call it the unhealthy burden of global public health. Yes, global public health is founded in migration, the consciousness about how to manage diseases that pass across borders. When people decide to go to another destination for whatever reason, and so on. So the emphasis has always been on infectious disease control. And as we have heard already a little bit about the international sanitary conferencing model, okay? We had already that between 1851 and 1936, we had about 13 such conferences. They were driven by Europe, laying practically the foundation of global public health. And it was exclusively an European initiative, if you like, maybe part of the New World, because United States came into the space much later through the international sanitary conferencing model. So what are the features? Of course, imperialism and colonialism, racialization of disease, even though Europeans brought diseases to indigenous populations, and in fact, in some cases, exterminated a whole indigenous population, but yet these populations were framed as the sources and channels of disease. So segregation was so important, even for the military. They built their own separate hospital. It was actually some kind of apartheid in the context of global public health. So European economic interest was of prime consideration. This was at a point when they went into science and laboratories to begin to expand on the germ theory. And of course, one of the benefits of it was the evolution of tropical medicine. But essentially, most of the decisions were done arbitrarily, and in fact, with certain degree of racism and xenophobia, with which they visited even the local population. The second phase comes really handy. For some reason, the WHO was born. Before then was the Health Committee of the League of Nations. And so we begin to see the emergence of new independent states and a tendency to begin to really look at global public health, to give it some degree of globalism, if you like, the tendency to bring some pluralist voices and inclusion into the space. And that's why, if you look at the WHO Constitution, there is elaborate in terms of talking about all, and not necessarily the powerful states. So human rights came into the equation, and it's so important that we begin to see some of the issues that came into play. A whole lot on infectious disease control and surveillance was part of global public health at this era, but it is split across equitable health services delivery and capacity. And that's where we don't have enough time to talk about the activity of non-governmental entities participating in this space. But one of the major features of this phase is constitutionalism. WHO Constitution, for those of us familiar with this document, the preamble is so robust. And of course, Articles 1 to 2, the objectives are 22. And if you read them carefully, they are divided between infectious disease control and equitable health services delivery. And so you see, along that part, since 2005 was the international health regulations, which came into effect in 2007. So these two documents provided a very robust sense of what a constitutional approach to global public health would look like. And so we begin to see a tendency to talk about human rights, so fundamental rights and liberties in exercise of global public health and respect for international law. So Articles 3 and Articles 42 to 44 of international health regulations are very robust in relation to what will be the undergirding principle for implementation of global public health measures. And of course, the WHO Constitution is also very, very robust in this area. So when you merge those two, you see a regime of constitutionalism. And one of my colleagues, and I think the next speaker after me, would have a lot to speak in relation to Article 43 of International Health Regulations. When do we call a public health emergency of international concern? In the first phase, it was dependent. There was nothing like this other than when do you globalize a disease outbreak? It was Europeans that made that decision. And for what purpose? To protect European interests. And there was no science around it, strictly so-called. But one important aspect of this phase that not much literature has picked up is the preservation of sovereign right of states regarding making health policies. And for all that we see about bordering and control, and for all the detailed prescriptions by the World Health Organization regarding at what point and what principles would you use to make a call, all issues about science and risk, about proportionality, about precautionary principle, when you stack it alongside the sovereign rights of states to make health policies, everything might fly out of the window. And that is a very problematic experience. Now, the next thing to present in terms of how has this constitutionalism been practiced, particularly the implementation of the prescriptions of international health regulations in real life. And let's look at two experiences we have had with Ebola and then the Omicron variant. Ebola, for most people in this field, know that it was first discovered in 1976. And you ask yourself, a very lethal disease discovered in 1976. What happened between 1976 and 2014 to 2016, where we had the first major Ebola outbreak in Central and Western Africa? And frankly, between that period, why was it eventually said to be a public health emergency of international concern? And I want to suggest this: the dramatic flights from Liberia, Freetown, Monrovia, to Lagos, Nigeria, was the catalyst. Before now, nobody considered Ebola to be a serious threat. But when somebody flew, and in Africa, flying is a luxury as opposed to necessity. High-profile people fly. And they landed in one of the most important commercial hubs in Africa, Lagos. And that is in Nigeria, the continent's largest economy by GDP. It was at that point that the Western media were able to pick up Ebola as a serious crisis. And of course, it caught the WHO napping. And for the first time, the United Nations broke protocol and set up United Nations mission on Ebola emergency response directly. And the Security Council passed a resolution. What's the point here? The point is that global public health is insensitive to peripheral people on the periphery and on the margins. It is only when there is a serious threat to the economic interest of the powerful states that stuff will begin to happen. And when it happens, it is with a tendency to protect and not necessarily with a view to trying to mitigate the crisis for everybody so that we have a clear sense of a global public health that is truly global. And so it is within 1 month of Ebola being found in Lagos that the call was made that it is a public health emergency of international concern. And of course, at this point in time in 2018, in Democratic Republic of the Congo and the parts of East Africa, this was actually spreading. And it took yet another year before a call was made for such a deadly disease with a higher death toll, higher than even COVID-19. Now, let's say, for example, that within this period, most of the countries that were ravaged by Ebola fall into the least developed countries of the world. Even by African standard, they are the most impoverished of countries. And therefore, you could say that some of them did not even have what we'd call, in terms of government institutions and establishment that will process such emergencies. They were not very resourced. And in addition to that, not only were they not resourced, there was serious communication problem in this area. And the international health regulations were yet to be practiced with some degree of experience. And this happened for the most part before the international health regulations kicked off. So let's say everybody was caught napping. But what happened several years down the road in 2021, where the South African surveillance mechanisms and scientists were able to spot the Omicron variant. You would have said by this time we have practiced the international health regulations, and South Africa, by every standard, is a very, very topmost country in the whole of Africa. And it was able to rise up to the challenge, and it spotted this variant. And what happened? Instead of South Africa to be rewarded, South Africa was isolated. The rest of the continent was punished. And we saw a lot of brigandage in terms of shutting Africa away, even when this continent reported the list of infections in COVID-19. So the whole world slammed its door against Africa. And what was the reason? Because South Africa played by the rules and was able to isolate the Omicron variant. When in actual fact, there are a lot of literature and statistics supporting that this variant may have been present in so many other Western countries, including the Netherlands, United States, Canada, Germany, and so many other places. But then Canada and United States, just like Colin mentioned at the beginning, were fast in slamming their doors against African countries. So what you see here is that not much, in my opinion, has changed in relation to the way we practice global public health. It is not radically different from the Eurocentric phase. It's just that a lot of optics has been injected into the conversation. Until we begin to see how to balance the politics and the science, and the whole idea of sovereignty and constitutionalism. And the WHO and international health regulation, they do not have any incentive for countries that play by the rules. Everything is based on recommendation, and countries are sticking to their sovereign rights. In all of this, Africa is the most negatively affected of all the regions, because Africa is most likely to have people who want to go to the West. They're likely to be the people that contribute significant degree of refugee population, and so many other indices put together does not stand this continent in good stead in this very regulatory free-for-all in cases of global health emergencies. I want to be able to tidy up this to say that we need to have the global health and its future premised on international solidarity. And one of the major problems is the exigence of global public health emergencies. We need to have it moderate sovereign rights. If we are talking about emergencies, even in constitutional principles, we have breached constitutional provisions to save some situation. One of the panelists has said between international and national, it is two sides of the same coin. And therefore, we should be able to allow the exigencies of global public health emergencies to moderate sovereign rights. We should be able to allow the exigencies of science. And of course, we have heard that science is not conclusive. Science is in evolution to tamper the politics of it all. And therefore, we have to go back to empowering the constitutional approach. And in an attempt to revise the international health regulations, we should be speaking about sanctions, incentives, and disincentives for countries that do not play by the rule. And if there is any takeaway from this conversation, in my humble contribution, we should have a new ethics of speaking disease, a new ethics of speaking disease, and to do away with the fallacy of disease directionality. So this is my reflecting conclusion. As we begin to look at the present overcast of pandemic incidences that are linked to anticipated intensification of climate change-induced zoonoses. So the whole idea is that there is no accuracy regarding the mapping of disease directionality, okay? Viruses are being transmitted by animals and humans and moving from one place, and with climate change disrupting the ecological order. So how could we begin to burden a particular racial group with disease, isolating and marking them out in ad hoc measures and punishing them and throwing away everything we have provided in the important texts about constitutionalism and the rights of the people? There's never been a credible basis for painting a region, a racial category, or a people on socioeconomic and power margins as natural channels of disease that threaten the diseased immune ward's powerful regions. And therefore, we have a new urgency to conjecture a 21st century global public health architecture that is based on science, international as opposed to national expediency, and a principles-based constitutionalism. Thank you very much.
Thank you very much for a fascinating presentation and really putting some very wise reflections out there for us to consider. Okay, we have one more speaker in this panel and really looking forward to, and the other speakers have set you up very well. We now have Professor Lisa Forman, who is an international human rights lawyer. She is a faculty member with the Dalla Lana School of Public Health at the University of Toronto. She holds a Canada Research Chair in Human Rights and Global Health Equity. And after all of the preceding speakers, she is going to help us reimagine the International Health Regulations, Article 43 on travel restrictions. So over to you.
Thank you, Jane. Let me move this down. Good morning, everybody. It's absolutely a pleasure to be at this conference and to be participating with my esteemed colleagues on this panel, this wonderful panel. Thank you, Raywat. Thank you, Colleen, for the invitation. And thank you, Giles Holland, for incredibly smooth logistics. So I am an international human rights law scholar at the University of Toronto. And in international law, as in many of the disciplines that are here today, the role of borders as public health tools has been strongly contested. The international health regulations, which are the world's primary international law instrument to address pandemic threats, the international health regulations were adopted precisely to ensure that states respond to infectious disease threats in ways commensurate with public health risks and which avoid unnecessary interference with international traffic. But COVID travel restrictions have interfered with international traffic in absolutely extraordinary ways. And the question of whether these restrictions have been commensurate with risk and strictly necessary continues to divide scholars across a range of disciplines, as this meeting illustrates. Now, however, we may understand the legitimacy of these restrictions within the international health regulations more broadly and within international law more broadly, I think what might be the most challenging part of COVID travels restrictions is what appears to be a tremendous disconnect between the travel restrictions that were implemented and what the international health regulations require when it comes to travel measures. And what appears to be an almost total failure of states to consider the requirements of the international health regulations to base such decisions on scientific principles, evidence, and advice from the WHO. And this in spite of the fact that the WHO discouraged international travel almost from the start of the pandemic, and in spite of the extraordinary social, economic, and human rights impacts of those restrictions. And as Chidi very ably illustrated, the worst instance, I think, in the COVID era of travel restrictions came when bans were placed on South Africa after it, in good faith, notified of Omicron. and the travel bans that were then immediately imposed on a range of other African states, where some of which where Omicron had not been detected, but not on European countries where Omicron was already present. Something not just grossly discriminatory, but deeply threatening to continue compliance with the IHR's aims of ensuring prompt notification of future disease outbreaks or variants. And these kinds of discriminatory, indiscriminate, ongoing, disproportionate restrictions, I'd say, are totally at odds with the objectives of the international health regulations, and undermine the legitimacy of the international health regulations, not just of Article 43 on travel restrictions, but of the instrument more broadly. And they deeply underscore the importance of reforms of this instrument, whether it's in the ongoing effort at the World Health Organization to reform the international health regulations, or in the form of a pandemic treaty, which is being negotiated, which will supplement and to some extent perhaps supplant the IHR in key dimensions of pandemic preparedness and response from a global perspective. So what I want to do in my time is focus on how we might interpret travel restrictions from the perspective of international law and international human rights law, not simply in the context of the IHR more broadly, but in relation to international human rights law criteria for interpreting laws and policies that significantly restrict human rights, which say that any significant restrictions of rights should meet the criteria of necessity, proportionality, and non-discrimination. And there should be a significant focus placed on the impact of such restrictions on vulnerable and marginalized populations in particular. And these are requirements that are to some extent already embedded within the international health regulations, and which are implicit in the IHR's inescapable relationship to other aspects of international law. So what I will do is give an overview of Article 43 in its context, and locate that more broadly in international law, touch on some of the evolving evidence that we've seen around travel restrictions and guidance, because these are some of the fundamental ways in which we can understand those the necessity and the proportionality of those restrictions, and then conclude with what we might want to see in terms of reforms of the IHR to ensure greater clarity, greater compliance in future disease outbreaks. The work that I'm going to present today draws from research produced under a World Health Organization grant to produce legal analysis of the IHR Article 43. And this was published with the wonderful Regine Habibi in the International Comparative Law Quarterly in 2021. Also draws from other work that I've participated in collaboration with colleagues at the Global Health Law Consortium on various aspects of the international health regulations. So this is Article 43 in totality. I present it here not to get into the details, nobody could tell what that means, but I want to just give you a visual of the article in its totality. You can see just by looking at it, this is not a model of concision. And I can tell you from a legal perspective, it is not a model of clarity. This is not a virtue of law. Law should not be inscrutable. You should not require a legal PhD to understand a provision. And certainly I think we can put some of the problem, but certainly not all, down to this lack of comprehensibility of and clarity of Article 43. So I'd say to understand Article 43, we need to put it in the broader context of the international health regulations. This is Article 2 of the regulations. This is the object and purpose of the regulations, which says that the central twofold purpose of the regulations is to prevent, protect, control, provide a public health response to the international spread of disease commensurate with and restricted to public health risks, and do so in ways which avoid unnecessary interference with international traffic and trade. And this focus on the necessity of interference, I think, is the crux of how to understand both the IHR more broadly and Article 43. So when the IHR were revised in 2005 into their current forms, it was explicitly to prevent states from implementing overly harsh and costly travel restrictions in response to disease threats that disincentivized states from notification. and to instead to commit to following WHO recommendations on this point. But I think what Article 2 also emphasizes is that interferences with international traffic should not be unnecessary if they are to comply with the regulations. So not to overmake the point, but necessity is central to whether travel restrictions should be passed. And limiting interferences with traffic is a core plank of the IHR. So Article 43 outlines the criteria and process for determining what a necessary interference with traffic looks like. And if we break it down to some of its core components, what it says is that while states should not implement travel measures in the ordinary course, they can implement measures beyond WHO recommendations, so long as the measures accord with relevant national and international law obligations, are not more restrictive of international traffic or invasive to people than reasonably available alternatives that would achieve the appropriate level of health protection, and are based on assessments of scientific principles, available scientific evidence of a risk to human health, or where evidence is insufficient, available information from WHO or other relevant organizations, and any specific guidance or advice from WHO. States that implement measures not covered by WHO recommendations must inform the World Health Organization within 48 hours of the measures and their health rationale, and must within 3 months review the measures taking into account WHO advice and available science. So breaking it down into constituent parts doesn't necessarily help any of us understand that much better what it requires. We still really are debating what some of these key elements mean. What is it? What are reasonably available alternative? What is the appropriate level of health protection? How do we define scientific principles, scientific evidence? And when evidence of risk is lacking, as it may be with a novel pathogen, what should risk assessment be based on, given that there is no recourse in Article 43 to a precautionary approach to travel restrictions? So the lack of clarity on these terms has prompted an enormous amount of legal analysis and interpretation. I participated in a pre-pandemic in an in-depth legal analysis of Article 43 with a group of international law, global health law scholars, where we interpreted Article 43 from an international law perspective and the rules of international law on treaty interpretation to consider the treaty in context and the light of the treaty's object and purpose, and located more broadly in relevant international law. And the argument that we made was that the requirement that health measures accord with relevant national and international law obligations must include obligations under international human rights law, and that the requirement to ensure that measures are not more restrictive or more invasive than reasonable available alternatives essentially embeds a proportionality clause into this text, which are rooted again, not just in obligations under international the international health regulations, but international human rights law more generally. So this is not an outlandish claim. The IHR itself requires that its interpretation and implementation be guided by human rights law. Article 3, which sets out its guiding principles, says implementation must be with full respect for dignity, human rights, fundamental freedoms. It must be guided by the UN Charter and the World Health Organizations, both of which include some extent of human rights provisions. And later on, there's a provision that says states should interpret the IHR to be compatible with other relevant international agreements. Obviously also includes human rights treaties, which govern a range of rights implicated in travel restrictions, both for travelers, for people unable to travel because of restrictions, and for the populations of countries impacted by restrictions. It's important to note that the drafting history of Article 43 itself indicates that earlier drafts far more explicitly prevented countries from imposing measures exceeding those recommended by WHO. And one of the drafts before the final only allowed states to exceed WHO recommendations if the measures did not conflict with international human rights law entitlements. So the explicit reference was taken to international human rights law was taken out of the final measure, but I think we can certainly understand the references to less invasive, less intrusive measures, the focus on necessity, the focus on least restrictive alternatives as reflecting the continuing imprint of these criteria. as do some of these other explicit indications that human rights should be guiding principles. So an assessment of whether travel restrictions are necessary, that requires not just that states assess at this point the evidence for public health risks, but certainly going forward, they should be considering the evidence of the efficacy from a public health perspective of these. And this is obviously going to be central to any considerations of necessity and proportionality. So the evidence for the efficacy of travel restrictions, or certainly of COVID-related travel restrictions, I think to some extent supports what we know from past outbreaks, that travel restrictions delayed but did not curtail the spread of COVID. And we've seen through a range of different, very highly credible, I think, studies, similar findings, a systematic review by Karen Greppen and her colleagues of 29 studies, which found early implementation an important determinant effectiveness, but that effectiveness was short-lived and dependent on commensurate domestic measures. Another systematic review by Burns finding beneficial effects and delays in outbreak spread for up to 85 days, and effectiveness also very much dependent on a range of contextual factors. So the studies seem to suggest some efficacy for short-term early restrictions, but that any efficacy wanes over time, and that a one-size-fits-all approach that doesn't take account of context doesn't appear to have any linkage to efficacy. And certainly the lack of evidence to support the kinds of public health restrictions that we've seen beyond initial stages, I think would undermine the argument for necessity. And to this extent would undermine the argument certainly for proportionality, given the absolutely extraordinary social and economic and human rights impacts of the restrictions. We know from prior pandemics the impact of far, far, far shorter restrictions. Peru was estimated to have lost $700 million after its 91 cholera outbreak, after restrictions were imposed in it. A plague outbreak in the early 90s in India, the travel ban that resulted was estimated to have cost India upwards of $2 billion. So whatever we know from previous pandemics, I think, are orders of magnitude smaller in duration and scale than the economic, social, and certainly the human rights impacts and costs of COVID-related travel restrictions. And it's worth noting that today, 2.5 years into the pandemic, many countries still have restrictive travel restrictions in place. This is drawn from earlier this week from the International Air Transport Association's travel regulations map, showing that most countries in the world continue to have partial restrictions in place. And I think I'd certainly argue that these impacts demand a far stricter standard of scrutiny for what triggers travel restrictions and what they should look like, and demands that when they're imposed, those negative impacts should be mitigated by solidarity and cooperative action, so that less well-resourced countries don't bear the economic and social brunt of travel restrictions at bans, at the same time that they have been shut out of access to the COVID vaccines that became a precondition for travel. And certainly I won't go into the details of WHO guidance in interest of time, but we can see a shift, this kind of shift towards finely considered risk assessment rooted in proportionality, non-discrimination, and necessity in the evolution of WHO's guidance. I won't, other than to say that while the WHO initially strongly recommended against travel restrictions, it shifted over time towards promoting time-limited, risk-based, evidence-based, coherent, proportionate restrictions rooted in solidarity and human rights. So let me close then by suggesting how we might reimagine travel restrictions, particularly now that IHR reform and a new pandemic treaty is on the table. So I think firstly, clearly we need a better Article 43. We need a better provision, of much clearer, much better defined a legal provision to let countries know when restrictions may be justified for novel pathogen, what processes and could ensure measures rooted in necessity, proportionality, non-discrimination, equity, solidarity. Certainly, proportionality would suggest that travel restrictions not be blanket, they must be clear, they must be used for legitimate aim, and they must be time-bound. I think the second piece is that if restrictions are imposed, there should be global solidarity and cooperation to mitigate their impacts by supporting the economies and public health responses of countries deeply disadvantaged by those kinds of restrictions, including, for example, states whose economies are heavily reliant on tourism. And the third and probably most important is that there needs to be accountability for non-compliance. Right now, state reporting to the WHO under Article 43 is not made public. We have only some indication in the annual reports that the Director General makes on the functioning of the IHR, where he gives a figure of how many states notified. We have no idea who notified, who didn't notified. So there are no consequences of any kind for non-compliance. And I think this is something that dramatically undercuts its efficacy. Certainly, even just transparent reporting could go a long way towards assuring at least reputational costs for non-compliance. But I think equally important would be to create enforcement and monitoring mechanisms that could bolster compliance. And maybe one way to achieve that is to assure that there's greater linkages between the IHR and other international mechanisms with the UN human rights bodies. For one, to give the WHO authority to address human rights compliance through existing IHR tools, like the Joint External Evaluation Tool, or through the use of existing UN mechanisms to push for human rights compliance, and like the Universal Periodic Review, where UN member states' human rights records are reviewed. I think in the absence of clarity, in the absence of accountability, I think we'll continue to see the IHR being toothless and ineffective as the world's primary tool to address pandemic threats, and we'll continue to see unmitigated, needless, discriminatory, disproportionate bans and restrictions, which will continue to dissuade states from promptly reporting in ways that will continue to undermine global health objectives. So I'll end there. Thank you.
Thank you very much. Can we get the microphones on here? I'm not sure if they are working. Hello, hello. Is that working now?
Yeah, it works. Yeah.
Okay, wonderful. Okay, so many things to think about, so little time. The good news is, number one, there's still another day and a half to go. And number two, there's going to be a book. So you'll be able to read more and more about all of these great topics. But let's just take a few minutes before the break to give an opportunity for questions. There's a microphone in the room. So for those of you in the room, please come on over to the microphone. We'll look forward to some great questions. And online, I am watching the chat and the Q&A. So we have lots of accessible spaces online for questions. And we have our first person at the microphone. Please go ahead and introduce yourself.
Hi, I'm Adam Houston with MSF. This question primarily for Professor Forman, but for anyone else who'd like to weigh in. When we're talking about human rights and the IHRs, there's of course also the state obligation, around the right to health and protecting the health of its own population. And we've seen examples like going back to the historical example of the Spanish flu. Helen Clark's apology in New Zealand a number of years ago, apologizing for when they come back to the colonial aspect as well, when they were controlling Samoa for not implementing the restrictions that had been seen in, say, American Samoa and the deaths that resulted. So, again, those state obligations to protect health and where that line is exactly. And so I'm just hoping you can perhaps comment on that.
Please go ahead.
Thank you.
I think so. Yeah.
Okay. Thank you for that question. And thank you also for asking the question and centering pandemic response in relation to the right to health, which is rarely done. including in the international context. And I think the question that you're asking really is, how do states balance the domestic rights of their country with international obligations around the spread of disease? And I think this maybe goes back to one of the questions that Colleen asked us at the front, is, you know, at the beginning, around the function of rights in this context. We've seen rights being used as trumps against the use of restrictions, which is clearly not an authoritative, persuasive, appropriate way to understand rights. I think the better way to understand rights here is in relation to the balancing of rights of various populations. And certainly I think what we don't see in government policy around COVID is a consideration of rights. I think it would be extraordinarily wonderful if human rights were being considered in, certainly in some of the ways that you've suggested. I think what we want to see is more of a balancing of interests be taken into account from a rights perspective by governments, which doesn't, I think, suggest that, I don't think that a right to health argument would support the kinds of travel restrictions that we've seen. I think that a more balanced approach would produce something different, more measured.
Thank you. Colleen, you have a question?
Yeah. Thank you. What a wonderful panel. And thank you for superb moderation, Jane. It was terrific. I guess two questions. I disagree with you, Lisa, on your interpretation of the evidence. I think, you know, when we see the numbers from New Zealand and we calculate what would have happened if the borders had been left open, thousands and thousands of more people would have died. And so when you think of the right to health and the contextuality of that, if some of these nation states, South Pacific states and so on, had to move very quickly, many, many more of their people would have died. So the IHRs, I think, need to be reflective of the different contexts that different states have. And I don't think that's in the draft now, and I don't think it's in what you're proposing either, because there's no aspect of precaution that is permitted in your redraft. And I also just wonder about the caliber of the decision-making. So I think there's been a lot of skepticism about the World Health Organization, and in particular, its initial response to COVID because of its origins in China and the role of China in funding the World Health Organization, and the role of other interests, economic interests, in funding the World Health Organization. So I wonder what you, all the panel, actually think about how do we approach that question, because the legitimacy of the lawmaker, I think, was under a bit of a cloud at the beginning of the pandemic. And so that may have also impacted the response. But yeah, like I know in New Zealand, Jacinda Ardern did the numbers calculation of whether the hospital system, the healthcare system could even tolerate what was potentially coming, and quickly did the numbers on the back of a napkin and said, no, it couldn't. So that's why they made the choice they did. Yeah.
Thanks. I'll open it up, whether it's Lisa or someone else on the panel that would like to take a go at that.
But I'm happy to go off to other people.
Okay, we're supposed to take a break very soon. So if anybody on the panel, and we can unpack it as the day goes on. That's also an option.
Happy to respond if nobody else wants to jump in.
Sure. Why don't you give us a
okay?
Quick.
No, look, Colleen, I appreciate that. And I think that strict divide between scholars, between people arguing around whether travel restrictions have been effective or not. I mean, that's the live question. I mean, I think my fear about a precautionary approach here is that it would simply permit what we saw. Unmeasured, unrestricted blanket restrictions. And I do think that there should be some caution in drawing lessons from what essentially island nations, continents like Australia, New Zealand, where you don't have the kind of permeable borders that you see in other places. I think that those lessons might hold true for comparable, but not necessarily for all places. That would be my response there.
Yes.
Yeah.
So
Okay, I'm going to go ahead, Chidi.
Sorry, I wanted to revisit the question on balancing rights, and what I may need to add there is that in pandemic situations, there is a radical disruption of activities and citizens' access to essential services. So my take is that right to health is robustly expressed in jurisprudence in terms of social determinants of health. And therefore, when a country wants to balance some of these competing rights, even those that make it trump cards and so on and so forth, there has to be a robust activation of every measure that is designed to mitigate the disruptions of social determinants of health. We talk about pandemic relief. We talk about access to people in isolated places and so on and so forth. So when a country is fighting a pandemic, there is right to health, there is human rights, or the trump card approach to human rights, and also part of what we have heard about management of information. One of the primary interventions would be to ensure, particularly for the most vulnerable, that their access to essential services and other social determinants of health that may be disrupted are not compromised in pandemic situation. And I believe that that is one major way of balancing some of these competing rights. Thank you.
Excellent. Great summary there. So I'm going to frustrate everyone with saying there's no more questions, but you can all, hopefully those in the room can chat amongst themselves and contact these speakers up front. I want to thank the 4 speakers. I think that was fascinating. Ray, thank you for your really interesting links between trust and communication and disinformation. Lots of questions left for you. Esyllt, thank you so much for that reflection on the influenza pandemic. I was fascinated by the way you drew the links between the great changes in our public health infrastructure linked to historic trends. Chidi, thank you so much. I had lots of questions left for you about the efficacy of the public health emergency of international concern mechanism and its efficacy. Lisa, amazing, really interesting issues around compliance and enforcement, and lots of questions left there. But that's a good way to leave things. We'll keep thinking. We'll keep hopefully getting some answers. Go have a little break, and everyone should be back at 10:30. Is that correct? Yeah. Okay, we'll pass you over to Sophie.
Yeah, we'll take a 10 minutes break. We're a few minutes late. So that will take us when, Colleen? 10:35. So we'll reconvene for the next panel on borders and mobility restrictions measured within regional and national spaces. Thank you.
Thank you.
Thank you so much for amazing work.